Hi, everybody. Alex Borzak here once again, Doctor of Nurse Practitioner student for Widener University. Here to talk with you with our last module of the day, dealing with transitions of care management programs. And in this module, we're going to talk about risk stratification of your patients within the transitions of care program, talk about the importance of it. And we're also going to talk about goal setting as well, because this ties into your risk stratification. And of all of the things that we've talked about within this program, of all of the things that you can do within a transitions of care program, the literature that was reviewed consistently reports that risk stratification and goal setting are your two top things that you need to have down pat in order to have a successful transition of care program and to reduce your 30-day readmission rate. So because of that, they've been pulled out of the regular cadre of topics and given its own presentation. So first of all, when we talk about risk stratification, what are we dealing with here? So this is going to be your key method for identifying patients that truly need intense individual intervention. And again, literature consistently supports the use of some type of risk stratification tool, and you have multiple options to this. You can do machine learning, you can use the LACE Plus score, CCI, Charleston Comorbidity Index, you can use hierarchical condition categorization, you can use the hospital score. All of these different tools out there perform really pretty much almost equal to the other clinically. Machine learning is a little bit more sensitive and specific compared to your other tools like your LACE Plus or CCI, just because it can deal with a lot more information and compute it at once. However, really, all of these different, because of the variables that you're trying to measure, all of these are clinically really about the same in terms of sensitivity and specificity to predicting rehospitalization rates. Ideally, you want to do risk stratification during this intake phone call before the initial follow-up appointment. So this is going to be that phone call that happens 1 or 2 days after discharge, when you are touching base with your patient, making sure they're still doing okay, doing your intake. This is where you can do risk stratification, because regardless of what tool you use, the information that you're going to be reviewing with the patient is stuff that's already going to be included within these risk stratification tools anyway. So it makes the job of the person who's doing this much easier, because it's the same information. They aren't going to have to go find additional information, most likely. And again, the whole point of doing this is we're assessing for the likelihood of readmission of this person within 30 days. Those who are at highest risk require the referral for additional services. And it's not good enough to risk stratify by one specific disease process by pointing out all of your CHF patients or all of your COPD patients or all of your diabetes patients, because not every CHF patient is going to be at a risk of rehospitalization, at least maybe perhaps at that point in their course of that disease process. So if you're directing that person to additional resources when they really don't need it, you are creating inefficiency. You are utilizing resources that could be better spent for another patient or better spent elsewhere for the same patient. So that's the big reason why risk stratification is so important. Current definitions for, and really what we're looking at is we're looking at moderate complexity patients, we're looking at high complexity patients. Those are two big categories of patients that we really want to capture because they have more stuff going on condition-wise, health-wise, that complicates their care. So current definitions that are used by many programs out there, a moderate complexity patient who would be referred for some level of services would be 2 or more hospitalizations or at least 2 chronic conditions with no regard to medications. Further, a high complexity patient or 3 or more hospitalizations in the last year, or at least 3 chronic conditions at least 10 medications. The problem with these definitions is they're very vague and very open-ended, particularly when it comes to medications. So 2 chronic conditions with no regard to medications, or at least 3 chronic conditions and at least 10 medications. That is a very wide net that you're casting, and it might be too wide, and you might still be getting patients that, yes, you're probably getting patients that need these transitions of care services. However, you're probably also going to get a lot of patients that really don't need these high intensity services and could be referred elsewhere. Other resources could be assigned to these people who don't really meet that intensity level. So instead, what we aim to do with this part of the project is to make our goal to predict moderate and high complexity patients that have a high potential for readmission before they have multiple hospitalizations or ED visits. Again, this is taking this from a reactive approach to a more proactive approach. And then also, we want to be able to identify barriers and gaps in care that can be addressed proactively to allow for easier access to health services. Again, the caveat to this is we might not be able to completely solve or completely remove a barrier, but we can at least lessen its impact on that ability of the patient to attend an appointment or to obtain medications or to gain the knowledge in order to use those medications correctly or follow the regimen that's been prescribed correctly. So where does risk stratification fall in the big long processes that we've been talking about, particularly within the last module? So this is our pre-hospital algorithm that we use to look at the NTOC 7 essential bundle. And where risk stratification falls is prior to that follow-up appointment, really right when that phone call is being made, we're doing this risk stratification. Not only are we looking for barriers immediate to get them to work on, to overcome, to get them just to this appointment, but we're also, again, doing this risk stratification at the same time so that when they do make it to this follow-up appointment, we already have some services lined up as options that the patient chooses to participate that they can do, and that we can plug them into right there as they are there for that initial follow-up appointment in the clinic. So we're going to talk about real quick a couple of different avenues that you can follow to do risk stratification. First of all, the gold standard is something called machine learning. This is an algorithmic approach utilizing electronic health records across multiple databases. So the nice thing about this is that it utilizes the metadata stored within the entire health system for that patient. So it can be all of the social information that's there as far as like social services, home, like residency status. Are they homeless? Are they transient? Do they have their own resident? Are they in skilled nursing facility? Are they assisted living, private residence, that kind of thing? Looks at all of their primary care appointments and results, looks at all the lab data, looks at all of the PT, any PT/OT, home health services, all of that. It pulls it all together and it comes up with a risk model of how likely this patient is, or how at risk this patient is for a readmission within 30 days. And again, these algorithms, they're very diverse and can include all morbidities and social factors. The more data that you have to pull into this model, this algorithm, the more robust the results are going to be. The downside to all of this is, of course, this comes at a cost, and this can be very expensive upfront cost to implement, getting your IT project going, getting it through, doing all of the machine learning, doing the bootstrapping, setting this up so that you can even run the algorithm, and then making sure that you have enough information, enough metadata to include in that algorithm to get accurate and sensitive results back. So because of that, it requires access to large and multiple databases for accurate predictions, which is fine for really large health systems, health organizations that have these records integrated already. If you're looking at a federally qualified health center or a standalone clinic or a small network of offices, this may not be feasible financially, first of all, to have the space, have the servers, have the technical expertise to set this up and maintain it, but also to have access to the data required to run it for accurate results. This is only as accurate and as good as the data that is available to pull into this algorithm. And machine learning is not supported by all EHR software. So depending on what EMR you use, you may not even have this functionality to begin with. And then a big important piece that is sometimes forgotten about, okay, fine, so maybe you are one of these networks, health systems that is very lucky to have machine learning utilized and have it right there on your dashboard for your patient, that if they're in the hospital, you can pop it open and look directly and see what their readmission risk is. However, that's great, it looks nice, but not everybody knows what that means. So not only do you have to develop this model, develop this algorithm, you need to define the parameters and make sure that everybody understands what this result that's spit out of this algorithm means, not just for the patient, but also for the staff. What does the staff do with that information that they have? If the staff doesn't know, then you're wasting, again, you're wasting time, you're wasting money, you're wasting resources better spent elsewhere on things where staff is actually knows what to do with the information that they're getting. So ultimately though, so if you're not able to utilize machine learning, whether you're in a very small network or very small practice that doesn't have those resources available to you, what tool do you use? So I mentioned before that all of these other tools, the LACEPUS, CCI, HCC, and so many other ones that are out there, the hospital score, these tools function clinically pretty much equal to each other as far as their predictability of rehospitalization risk goes. So ultimately though, you want to find something that is going to hit really these big four requirements. It needs to be quick, able to evaluate risk utilizing data already being abstracted, free to access, so there's your cost, availability for download on iPhone or Android, particularly if the EMR that you're using does not support the ability to pull in from online sources, pull this tool in online. So you need to be able to get something that will automatically calculate it for you, pull it in either on a phone or something like that. And it needs to be free if you're going to have your employees download it onto their phone. You don't want to add another expense to them either, because that's going to decrease the likelihood of them using it. Furthermore, it needs to have a high sensitivity and specificity of predicting rehospitalizations and ED usage. And those are the guidelines that were used to determine which scale would be most appropriate for this clinic to use. So we were able to narrow it down to two tools that would be most applicable and easiest to use for this specific clinic. So the requirement, again, quick, able to evaluate risk utilizing data already being abstracted, free to use. Both of these have apps that are available for iPhone and Android. So what we did next is, so we have these two tools here. We aren't quite sure which one to use because clinically, the clinical significance, they're both pretty much equal. One doesn't really outweigh benefits of the other because they both meet these requirements that have been set forth. So we did an analysis on statistical sensitivity and specificity to really tease these two apart to see which one would be most beneficial for the clinic to use. So our goal with this little study was to identify the tool with the highest sensitivity and specificity of predicting rehospitalization and ED usage statistically. We're looking at statistical significance, not clinical significance in this. We've already established both of these provide clinically significant results. So in order to delineate which one we want to use, we need to figure out statistically significant results. And then second part, what we did here, and we'll talk about in a little bit, is identify defining characteristics of patients that would be appropriate for low, medium, high risk categories. So the literature doesn't go this far. The literature goes far enough to say risk stratification tools work. These are some of the ones that are out there that are beneficial, and this is how they function. But the literature has not gone out and actually described what exact these risk categories look like, and what possible comorbidities may be included in these for goal setting. So again, the ultimate reason why we're so concerned about risk stratification to begin with is so that our net that we're casting isn't too wide to get a whole bunch of patients that really don't need to utilize the services that we have, but also so that we don't cast net that's too small, so that we don't exclude individuals that would truly benefit from being assigned different resources within the clinic itself. So let's take a look. So what we did is we reviewed, when I say we, that means I reviewed 1,307 charts that were visits of ED follow-up visits, hospital discharge visits, and also new patient visits over a 6-month period of time. And then what we did is we compared the LACE score, let me back up a second. The LACE score and CCI score were calculated for all of these 1,307 patients. We did a correlation to see which one had the highest correlation to predicting readmission for these patients. And then once we found out which one it was, we then looked at the 307 patients over the 6 months that had a readmission. And then we examined, we ended up looking at LACE score. So we examined the most frequent LACE score that within these 307 patients that popped up. And then we delved even further within that subcategory to look at the frequency of comorbidities of these patients with those LACE scores. So that's the general outline of how we approached this problem of determining which score to use or which tool to use, and how we're formulating and what comorbidities we're paying attention to set up our goal setting part of the transitions of care pathway at the end of that first initial appointment. So let's back up. Let's take one more look at this then at the very beginning. So we took at those, again, that 1,300 or 703 patients, and we calculated the LACE Plus and CCI score for all of those patients. So every one of those patients, 1,703 patients, had a LACE Plus score and a CCI score, and we correlated that to how well they predict readmission. And the interesting thing here, and is sort of expected, that both of these scores had high correlations to predicting readmissions for these patients. However, the LACE score had a slightly higher correlation compared to the Charlson Comorbidity Index, or the CCI score. We also looked at the area under the regression curve and calculated the C statistic. And again, the LACE Plus score had a higher C statistic, 0.773, when compared to the CCI tool, of a C-statistic of 0.645, which then again shows that the LACE plus score is more sensitive at predicting readmission when compared to the Charlson Comorbidity Index. So with that, the LACE score was chosen as the scale to utilize for risk stratification over the Charlson Comorbidity Index scale. What we did next then is look at the 307 patients that had a readmission within 30 days that were just general, whether they were avoidable or not avoidable readmissions. And we took those admissions and we looked at the LACE scores and looked to see what were the most frequent LACE scores of the patients that were readmitted. The one that had the most frequency was the LACE score with 29 patients out of 307, broken down by month here. So every month that of the study period that we looked at, that's the average of how many, not the average, that's the actual frequency of patients with a LACE score of 11 that were readmitted within 30 days. Over on this side, we have more descriptive statistics, and a couple of things here to point out is as we expected, the mean age of readmission was 56.5 years old. However, we had a range of 11 years old to 74 years old. And this is actually really important to note because, and this does relate back to the literature does demonstrate that the LACE score is sensitive and specific to predicting pediatric patients' readmission risk. And this confirms it in the order that we do have pediatric patients that were identified as being, that have been readmitted within 30 days with this LACE score. The other thing, two other interesting things of the descriptive data here is hospital discharges had the most of 23 people had a LACE score of 11 that were readmitted within 30 days. Also, just over half of the patients attended their appointment. This ties directly into what we were talking about back in module 3 with the PSQ-18 score, that a lot of patients were attending these appointments, but there was a low probability of these appointments being substantive to actually impacting the care on an outpatient basis for these patients. And then this is further confirmed that 21 of these patients, 21 of 29 patients were readmitted to the hospital in 30 days. In 20 of the 21 that were readmitted would have been considered an avoidable readmission utilizing CMS guidelines of the readmission was in some way associated to the original admission, or the additional criteria that was applied to the readmissions was that it was a complaint that could have been taken care of in the primary care office. So 20 of the 21 patients that were readmitted could have been avoided had they been adequately stratified and identified prior. The other part of this stratification was that we looked at the next level. So the LACE score of 11 had the highest number of patients in one scoring that were readmitted within 30 days. The next 3 scores here, LACE score of 7, 8, and 9, accounted for almost a third of the readmissions that took place. The total number between all 3 of these scores was 79. When you take the 29 from that had a LACE score of 11, you're looking at almost half of these patients that were readmitted had a LACE score of either 7, 8, 9, or 11. So this is the majority of patients that were readmitted to the hospital within 30 days over that 6-month period of time. So these are the patients with these scores that we want to focus on the most at this point in time. Again, kind of looking at the descriptive statistics, this is something very interesting, something very different. The mean age range of these patients was a little bit lower than the mean age range for patients with a risk score of, with a LACE score of 11. So this, for 789, the mean range was 45 plus or minus 18. Again, predicting readmission rate, minimum age of 2 years old to a maximum age of 84. So that opens up a wide range, a much wider range of demographics. Basically, the entire practice kind of falls within this category of LACE 789, which emphasizes the reason why you need to have this risk stratification in place to really cut through the bulk of patients and really sit down and identify who needs these resources. Again, hospital discharges accounted for the most appointment type that had a readmission within 30 days. And again, the majority of patients attended their appointment. And then 62 out of these 79 had a readmission in 30 days. And then 54 of these 62 were avoidable readmissions. So then what we did after that, after we understood what scores need to be addressed, we looked at comorbidities that were most frequent with all of these LACE scores. So on the left-hand side of the graph of the chart here, LACE score of 11, on the right side, LACE score 789. Those areas, comorbidities that are bolded, are specific to these LACE scores. So patients with a LACE score of 7, 8, or 9 had a higher frequency of having a vitamin D deficiency or PTSD as a comorbidity. Patients with a LACE score of 11 had a higher frequency of having COPD, CVAs, or TIAs listed in their population. That wasn't a part of the LACE score, patients with a LACE score of 7, 8, or 9. Also, I missed here, bipolar was a comorbidity of LACE score 7, 8, or 9 as well. And what this helps us understand, first of all, are comorbidities that may be contributing to these readmissions that we need to focus on in part of the clinic processes in care, emphasize in treatment and care for these patients on an outpatient basis. But then also this translates into goal setting as well. Can these be managed through care management services, or can these be nurse-driven interventions? Or what comorbidities that are most frequent need to be intervened with by a provider, whether they need additional outpatient testing, lab work, imaging, or they need that provider referral to specialists, whether it be nephrology, neurology, pulmonology, whatever it needs for further workup or management. So this then pulls us right into goal setting, how our risk stratification is going to impact our goal setting. And remember, this is our ACMA patient flow, our visit flow. And this is, remember, this is right where our goal setting is taking place, right in that follow-up appointment with the care manager, with the primary care provider, and the patient. So before all of this risk stratification is done, is say, hey, this patient meets criteria. They have these comorbidities, which are highly frequented with this LACE score. We have a possibility to provide some interventions here because these are occur most frequently with this risk stratification score. Maybe we need to do some additional interventions with them and curb any potential readmission that they may have within the next 30 days. before they come in with the appointment, this gets sent to the primary care provider, this gets sent to the point person for care management, and then they all convene together with the patient at the appointment where they say, hey, we notice that you have this, 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 and this. We have these services available here at the clinic. Would you be willing to be a part of our care transitions program and allow us the opportunity to work with you and get you in a good setting so that you don't keep going to the hospital, keep going to the emergency room for all of these different issues that we can help you manage and get under control out of the hospital. And how this looks is this is all done as part of the flow sheet within that phone call that is being done by our office person, by our transitions nurse, who is doing that initial intake phone call. So this is all done as part of that initial work, where we have it built into the charting system where they actually compute the LACE score, they actually compute the CCI, the Charleston Comorbidity Index, because this is still, even though the CCI score doesn't give us the statistical edge that the LACE score does in predicting readmission, the CCI score is still very important to know because it's still clinically significant at predicting morbidity and the need for certain resources that might not necessarily be readily addressed in normal goal setting with the patient. So we have all this, they get down through, they complete all of this, so they get the final score at the end. So it's LACE score of 11. Then we check on this box, the final score, is it the LACE score 4, 7, 8, or 11? Yes, it is. So then this pops up as you need to complete additional indicators. And this is where the provider and the care manager are sitting down with the patient in the initial follow-up visit, is where this is going to be completed. So say, for example, so we have a patient with a LACE score of 11. So this is the flow as it looks like in the chart. This can be part of your HPI within your progress note for the visit. So complete additional indicators. So this person has a LACE score of 11. So we can use the LACE score 11 in the following communities or comorbidities are present. So this is a test patient. This isn't actually a real patient. This is just a demo. This is a working test chart that's within the clinical system. So say, for example, this patient has comorbidities of hypertension, GERD, hyperlipidemia. So these three have been identified as being most frequent, occurring most frequently with a LACE score of 11. So these are comorbidities that may benefit being addressed within the care management setting. So these are selected, and then the next step that happens is something went wrong there. So we have all these, sorry about that. So we have all of these selected, and then what we do next is we can have the option of referring this patient now to care management, and we can break it down between these interventions can be nursing interventions, or these interventions need to be provider level interventions, depending on what kind of comorbidity we're talking about and what kind of intervention needs to happen to manage these most appropriately. And then while they're there in the visit, so we've identified, first of all, whether or not they're at a higher risk of being readmitted to the hospital. Secondly, we have identified comorbidities that the patient does have that are highly frequent with patients of this particular LACE score with this rehospitalization risk. Now what we're doing is we're delegating care management tasks to either nursing driven interventions or our provider level interventions. So not all of this is getting to one person and they are trying to do some sort of intervention that's inappropriate for their scope of practice or inappropriate for the resources that they have at hand. We're delegating those to the most appropriate resources. And then also we're giving those resources some idea of what we want to see at the end of the 30 days. And this is all developed with the patient in the room and they're on board with these goals. Then of course, also we have the option, give the option to the primary care provider to not refer, make no referral at this time for this particular condition, because they may already be optimized. They may already have gone to the extent of their cholesterol control. It's under good enough regulation that we really don't need to expend the energy any further at this time to trying to get that under wraps for the patient. And once we have that, now we can take that information, we can plug that patient into our care management program, our transitions of care, that segment of the transitions of care program, and we can take care of them for the next 30 days with a ultimate goal already delineated that the patient agrees on, which is going to heighten compliance for the patient to the algorithm, to the treatment. And we're doing this in a way that is cost beneficial. We've already looked at this. Our predictive model shows that this is going to provide us with solvency from a cost saving standpoint. So this is our AutoWOD model once again. So we've gone through over the last 4 modules, we've really picked apart the transitions of care program. Again, to summarize everything back again, we're going to pull out our AutoWOD model, look and see that we've addressed all of these different segments of this evidence-based practice standard that has been developed that now can be implemented into our clinic. With that, this concludes not just this presentation, but also these modules on transitions of care. I hope that they were beneficial, and I hope that you were able to pull away some information on either how to make your process more efficient or how to even start the process of building your own transitions of care program within your clinic. I would ask at this point, if you don't mind, pick up your iPhone, pick up your Android phone, open up the camera app on your phone, point it at the QR code, tap that link, and that's going to take you directly to the survey. If you don't mind taking just a few minutes to complete that survey, provide some feedback on the quality of this presentation, and get your thoughts on whether or not you are going to take some of this information and be able to implement some of this into your own practice. That feedback would be most beneficial. Thank you again for your time, for not just listening to this presentation, but to all of the presentations within this module. Please reach out if you have any additional questions or concerns. Thank you guys very much.